Dear students, the topic of our conversation today is hypovolemic shock. First of all, in this lecture, I will talk about the case, introduction, and study questions, and hypovolemic shock in the complete detail. First of all, we will discuss a case regarding the hypovolemic shock. The case is Mustafa, a 22-year-old Saudi medical student, was driving his car at a speed of 145 km per hour without fastening his seat belt when he was involved in a single vehicle automobile accident. When attended by the Red Crescent emergency team personnel, no information was available about the time of the accident. This is a scenario regarding the Mustafa, a 22-year-old Saudi medical student. He was driving in the car and he met an accident and the emergency team arrived there. Now we will put this scenario into the hypovolemic shock. Continuing the scenario, he was found to be agitated and complaining of the abdominal pain. His airways was checked and that was patent. At the scene, he was breathing at 32 breaths per minute with the blood pressure of 90/60, that is significantly low, and a pulse rate of 130 beats per minute. He was placed in a hard cervical collar so that his ABCD maintenance should be just like his airway and the breathing should be maintained on a backboard and transported to the emergency room. Upon arrival, his vitals were checked again and his vital signs were the same with a temperature of 36 degrees Celsius. His abdomen was markedly distended. Apart from the past discussion, his abdomen was having ache sometime, but now his abdomen is markedly distended. His hands and feet were cold, his legs mottled because of the accident. An NG tube, that is nasogastric tube, revealed green liquid. A urinary catheter revealed dark urine. His hemoglobin is 7. His fast examination is positive in Morrison's pouch. So, the question arises, what acid or the base category would be expected in this particular case of hypovolemic shock? What is the effect of this kind of shock on the vital organs such as kidneys, heart, lungs, brain and intestine? What would be the cardiac output of this patient? Continuing the scenario, I would like to now introduce you regarding the hypovolemic shock. So, hypovolemic shock is an emergency condition in which severe blood and fluid make the heart unable to pump enough blood to the body due to decreased preload. The diminished preload decreases the cardiac output and the vascular resistance increases in an effort to compensate for the diminished cardiac output and maintain perfusion to the vital organs. It then leads to the multiple organ failure. This was a technical definition of the hypovolemic shock. In simple, you can say hypovolemic shock is nothing but the loss of the volume, loss of the blood that significantly decreases the cardiac output that leads to the multiple organ failure. So, the causes of the hypovolemic shock has been divided into the two categories. The revealed hemorrhage, that is the external hemorrhage that you can see by your naked eyes in cases of the penetrating trauma, open arterial wounds, as you can see in the picture. Coming towards the second category, that is concealed hemorrhage, also known as internal hemorrhage, that is hidden from your naked eye, but you can watch it as a bruises on someone's body. It occurs in intra-abdominal bleeding, aortic aneurysm, rupture of the aortic aneurysm. Other causes of the hypovolemic shock that significantly decreases the volume or depletes the volume from your body. These include the burns. Burns are that category that causes significant hypovolemic shock. A patient has certain type of burns, especially the heat burns. Other causes are the severe vomiting and diarrhea that also produces the lactic acidosis, metabolic alkalosis and electrolyte loss, as well as the loss of the volume, excessive diuresis, use of the diuretics and other variable causes that may cause the shock. So, the classification of the shock has been categorized into the 4 classes: class 1, 2, 3 and 4. And all the classes we would like to see in detail the blood loss. In class 1 the blood is up to 750 ml, and class 2 that is from 750 to up to 1500 ml, class 3 1500 ml up to 2000 ml, and the class 4 that is more than 2 liters. So this amount of the blood loss or the volume loss, the patient will present with each category of the hemorrhagic shock. So blood loss in terms of the percentage up to 15% in class 1, 15 to 30 in class 2, 30 to 40 in class 3, and more than 40 in class 4. Coming to all the other features, that is blood pressure. It is usually so rapidly when you are having a confrontation to an accident. Just by checking the blood pressure you can assess whether in which category you can put the patient in the hypovolemic shock. That is blood pressure, if it is normal, consider it the class 1. If it is again normal, that's class 2. And class 3 there will be the decreased blood pressure. In class 4 there will be a significantly decreased blood pressure. I mean, the most specific and the most common feature we usually look for the hypovolemic shock is the urine output. Consider this second line, that is second loss line, urine output. If urine output is more than 30, that is considered to be the class 1. If that is 20 to 30 ml, class 2. 5 to 15 ml, class 3. And significantly there is no any urine, like negligible urine, oliguria, anuria, the person will be labeled as class 4 of the hypovolemic shock. So the question arises, what acid or base category would you expect in this case? Like the patient having met an accident. So what kind of the acidic and basic changes in the pH changes will occur in that patient? Coming towards this, the effect of the fluid loss on acid-base balance is variable. Although many patients maintain a normal extracellular pH, but either metabolic acidosis or metabolic alkalosis can occur, as I already mentioned in the vomiting and diarrhea. There could be either metabolic acidosis or the metabolic alkalosis. While the significantly you can see the lactic acidosis is common in cases of the hypovolemic shock, because there is significant loss of the blood. Significant loss of blood or the volume that leads to the hypoxia. This hypoxia will deplete the ATPs. This depletion in ATP will in turn produce the lactic acid pathway. That lactic acid pathway will in turn produce the lactate. This lactate will be accumulated into the blood, leading to the lactic acidosis. So, lactic acidosis is considered a type of metabolic acidosis. It's a physiological condition that is characterized by low pH in the blood tissue and the blood accompanied by the buildup of the lactate, as already mentioned. Lactic acidosis is characterized by lactate level of more than 5 millimoles per liter or the serum pH less than 7.3 pi. Among all the types of lactic acidosis, type A lactic acidosis is the most common type of hypovolemic shock. So the next question arises, what is the effect of this kind of shock on the kidneys, heart, lungs, brain and intestine? We will study all these in brief and the short way. So the kidneys are the first organ that has to be affected in case of hypovolemic shock. The urine output will be decreased due to renal hypoperfusion, leading to decrease in the GFR, and the urine output will be ultimately decreased. Based on this, blood loss that is more than 750 to 1500 ml, urine output will be mildly affected. If the blood loss is from 1500 to the 2000 ml, urine output mildly or you can say severely affected. If the blood loss is more than 2000 ml or the 2 liters of the blood, the body will show the signs of oliguria or anuria. So, how the heart will be affected? The cardiovascular signs we usually encounter during the hypovolemic shock are due to the adrenergic response to the blood loss. Like in shock 1, there is no response, but in shock 2, the patient will have the tachycardia due to catecholamine release. In shock 3, patient will have the hypotension along with the tachycardia. In shock 4, the patient will have the very weak pulse. Capillary refill will be undetectable or very low. The skin will be pale and moist, and blood pressure will be significantly low. Coming towards the lungs, another vital organ, the tachypnea due to the central nervous system chemoreceptor stimulation by the decreased pH and hypoxia already mentioned. Due to the lactic acidosis, there will be the decrease in the pH. This ultimately leads to the triggering of the chemoreceptor stimulation that leads to the tachypnea. How the brain will be affected? Symptoms of the brain are due to the cerebral hypoperfusion and the acidosis. Loss of blood volume. Loss of the blood leads to the hypoperfusion or low glucose level towards the brain. So, in class 1 of the shock, there will be no changes towards the brain blood because that is not the significant volume. In class 2, patient will have the restlessness, anxiety or agitation. In class 3 of the hypovolemic shock, patient will have the marked anxiety and the confusion. But in class 4, he will be having drowsiness even into the coma. How the intestine of the patient with hypovolemic shock is affected? Decrease intestinal motility due to the intestinal hypoperfusion. This leads to the bilious aspirate. As I already mentioned in the scenario that NG tube was passed and patient was having the green liquid. So this green liquid is actually the bilious aspirate in the NG tube. So the last question is, what would be the cardiac output of this patient in the particular case? So due to the hypovolemic shock that is characterized by loss of intravascular volume that results in the decreased preload. As the preload is decreased, there will be the decrease in the stroke volume. As the stroke volume is decreased, there will be the fall in the cardiac output. So, the initial hemodynamical abnormality of the fluid loss activate the compensatory mechanism under the neuroendocrine control, which maintain the adequate central perfusion despite the fall in the cardiac output. However, our system cannot compensate such a great loss of the volume. So, systematic vasoconstriction may lead to the tissue ischemia, hypoxia, and eventually altered cellular function and global organ dysfunction. So, this is the pathophysiology of hypovolemic shock. Decrease in the intravascular volume due to loss of the blood, loss of the water from the body, as in case of vomiting, diarrhea, burns. That leads to the decreased venous return towards the heart. Decrease in venous return ultimately leads to the decreased ventricular filling. If the ventricular filling is decreased, heart will be unable to pump sufficient amount of the blood, so there will be the decrease in the stroke volume. This decrease in the stroke volume leads to the decrease into the cardiac output. If the cardiac output is decreased, all the vital organs of the body will have the inadequate tissue perfusion. This inadequate tissue perfusion will lead to the death of the certain organs of the body. So, this was all about the shock. If you like the video, if you understand the hypovolemic shock in the comprehensive manner, please subscribe my channel and press the bell icon. Thank you.